I'm Cheryl Whitkey. I'm Director of Safe Communities of Madison and Dane County, and I'll be your MC today, sitting in for Carla Gaines. I'm pleased to welcome you to the Ending Deaths from Despair webinar series. To our knowledge, it's the only of its kind in the nation. On behalf of Dane County Executive's Ending Deaths from Despair Task Force, we thank you for joining us and for being part of the solution. The goal of this webinar series is to save lives in Dane County, to help set a standard for communities around the nation grappling with deaths from despair, to help us understand what underlies these deaths from despair from the perspective of people in pain, and to provide tools to all helpers who are working to prevent them, and to lay the groundwork for continued conversation and action on how to make Dane County's mental health and substance use disorder treatment system accessible, culturally competent, and effective at eliminating all deaths from despair. Today's presentation of the series is entitled Finding a Reason to Live, the Etiology of Suicide and Provider Self-Care by our friend Meghan Henderson. Meghan has her Master's of Science in Social Work and is a licensed clinical social worker. She's the clinical practice leader in behavioral health at UnityPoint Health Meriter. In her current position, she provides leadership to advance professional nursing and other professional practice. The clinical practice leader is responsible for assessing, planning, implementing, and evaluating clinical programs to meet the needs and improve outcomes of patients, patient populations, the organization, and the system. Meghan is a leader of the Zero Suicide Initiative at UnityPoint Health Meriter Hospital. Her special interests lie within mental health, including working with individuals with chronic suicidality, exploring shame resiliency, and working with caregivers and families to help them better understand their loved ones and set helpful, realistic boundaries. We also have Kara McCaffrey with us today. She's a co-coordinator of this webinar series. Kara is passionate about suicide and mental health after losing her brother in 2005. She works at EPIC, where she leads the Suicide Prevention Work Group. She's honored to be a member of the Zero Suicide Collaborative and Ending Deaths from Despair Task Force. Kara will be assisting with questions from the audience later in the presentation. I want to thank you all for being here. And this will replay if we run into technical difficulties, but it's smooth sailing, it appears. And now I'll turn it over to Meghan to begin. And again, thank you, Meghan. We're really honored to have you here with us.
Thank you all, and thank you, Cheryl, for the introduction. As Cheryl said, my name is Meghan Henderson. And this is, we're going to be talking for the next hour. Going to have time for questions at the end. Cheryl did a lovely job with my bio. Here's my professional picture. And I'd encourage my workforce to buy me a professional headshot, because this was the picture I had been showing at all my conferences. But so now I had this professional one, but I still really just enjoy this picture of me waving, because that's something I often do in pictures. So as Cheryl said, I'm a psychotherapist. I've been a psychotherapist for 14 years now. I've been at UnityPoint Health Meriter for the last 6 years. I'm also a graduate. I'm a lecturer at the University of Wisconsin. And I often have the tagline that I, often volunteer for things, and sometimes even too often, as I'm sure a lot of us are guilty of. But very happy to be with you all here today. We're going to be embarking on a little bit of a journey over the next hour together. And so just a kind of reminder that this can be really hard work. So to take care of yourself during this time and after we are in this together. I get so much strength and resiliency from being a part of the community of safe communities and of all of Dane County, working with folks who are both struggling with mental illness and working to take care of folks who experience suicidality. So in this hour, we're going to be talking a little bit about what makes someone suicidal, but also how to care for ourselves if we are the ones supporting individuals with suicidality. So we're going to kind of bridge those two topics together. So a helpful grounding moment that I think is a good reminder is from Freud. Some of you might have some feelings about Freud. I sure do. A lot of them are positive. Some of them are strange. But I think, Freud has this quote of, we are never so defenseless against suffering as when we love. And I think that's a really helpful grounding moment when we get concerned of feeling overwhelmed, or when we experience suffering as caregivers or as family members. It's often because we care a lot. And so that can just be a really helpful reminder. It's also a really great clue that we do have to make sure we have a good self-care plan if we are in this field, because when we really care about things, we are more susceptible to burnout and all that comes with it. So what is suicide? Suicide's been described as a lot of different things. There are some helpful things, ways to describe suicide. There are some unhelpful things. I remember one of the first times I learned about suicide, there was the phrase of, it's a permanent solution to a temporary problem. I think sometimes that can be really unhelpful to clients who are struggling because they don't see their problems as temporary. I often describe it as the wish to die becomes greater than the wish to live, right? I think a lot of folks who experience suicidality have ambivalence about suicide. So they have some desire to live, even if they have a greater wish to die. It's when does that table turn that one overpowers the other? I'm going to be sharing a little bit of my own experiences working in this field. So this is a little graph I made of my own understanding of suicide. And it starts at the beginning of kind of when I first learned about suicide to where I am now. I'm going to come back to this later in the presentation, but I don't know who all of you are, who's all watching this. And so I think it's just kind of a reminder that it's okay wherever you are. Maybe this is the first time you're ever tuning in to learn something about suicide. Maybe this is the 50th time and you're already somewhere on your trajectory. But I think we all have a trajectory of learning when it comes to anything, but particularly with suicide and as complicated thing as suicide. So it's a little preview. I'm going to be coming back to my own journey with understanding suicide a little bit later. There's a lot of unhelpful myths about suicide. And so I think one of the benefits of a program like this is it can help to sort of eradicate some of those myths or replace some of those myths with facts. So here are some common myths that still exist within the healthcare system and within our general population. The idea that talking about suicide can make someone suicidal. That's absolutely not true. We know that. Actually, talking about suicide can reduce some of the shame and secrecy around it and actually increase the likelihood that someone survives a suicide attempt or survives their suicidal ideation. That people who talk about suicide aren't the ones who complete suicide. So this idea that there are talkers and there are doers, again, not true. There's a reality that some people die by suicide having never really confided in people. But sometimes there's this myth that people who talk about it aren't actually going to do it. And that is so damaging for so many different levels. The myth that for some suicide is inevitable, again, not true. I think I was even taught that. I haven't been out of school for that long, but I was even taught that in school that, mental illness can be fatal. And there's some reality that some people do die by suicide. And I would say that every suicide is preventable. If people make a sublethal attempt, they're not really suicidal. Again, really harmful myths that are perpetrated out there. If someone makes an attempt, at least part of them had a wish to die. And this thought that suicide attempts often takes weeks and months to plan. That's not true. A lot of suicide attempts are quite impulsive. And so a lot of work is being done with suicide prevention to reduce access to means of suicide because they are so impulsive. So when I say means, we're talking about how they would die by suicide. So reducing access to guns and medications that are kind of readily available because often, like I said, suicide attempts can be quite impulsive. There's a lot of data out there about suicide. If you're data hungry, we can get you more data. This is just a little bit of a sneak peek into some of the data, particularly for Wisconsin and Dane County. So in 2016, Wisconsin was kind of right smack dab in the middle of the rate of suicides. Wisconsin had a total of 866 deaths by suicide in 2016. Again, about 3 to 1 male to female, which is pretty common in terms of who dies by suicide. There's some stats here about in Dane County in 2016, there was 80 deaths by suicide. Again, we saw 63% of those being male, and some more information there. Folks who, this data reflects the population of Dane County, obviously. So I think in different, more diverse counties, your data is going to look really differently here. I think another stat that I always find really interesting and helpful in grounding is that there's usually 4 times as many deaths by suicide in the United States each year than homicide deaths. So, again, there's about an average of 120 deaths by suicide a day. And so really impactful and really important that we're doing this work and having webinars like this. Suicide has been in the top 10 leading causes of death in the last, over 20 years, 50 years probably. And it's the only top 10 leading cause of death that hasn't reduced in incidence. It's actually increased in incidence nearly every year. So again, a plea to have this be on people's radar and be something we're focusing on as a community. A more recent statistic here are deaths by suicide in Dane County in 2020. Gunshot wounds and use of guns to die by suicide are one of the most fatal ways people die by suicide. So across the country, you're going to see these numbers. These are pretty equivalent across the country and across the states, that people who die by suicide are often dying by gunshot wound. Sorry for switching screens there. So I had a mentor. His name was Tom Ellis. His name is Tom Ellis. He's still my mentor. And I had some hesitation about working with folks who were suicidal. I was pretty terrified of it when I was new into my career. And he wanted me to get a little additional training on it. And I was like, I don't know if I want it. And he was like, listen, Megan, the question's not whether you're going to see a suicidal patient. It's whether you're going to know when you're seeing one. So I think that's really sort of helpful, I think, for clinicians to have some hesitancy to get more training. Is it's just going to help you be better able to be there in the moment with folks. It's not going to necessarily change who you're seeing as a population. Now, for me, it did, because this has become like a lifelong passion, suicide prevention and assessment. But I think, again, just sort of looking at that data, suicide is pretty prevalent. So if you're a healthcare worker, you've worked with someone who has been suicidal before. We can sort of know that to be the truth. So it's not whether, it's if you know who you're caring for in those moments. We're going to talk a little bit here about sort of the etiology of suicide, or what makes people suicidal. And I think for a long time, the mental health community sort of fell back on this belief that if we were treating depression, we would treat suicidality, and it's kind of in and of the same. And in fact, a lot of healthcare systems still use depression screening as sort of like the check mark for their suicide screening, which what we know is that they're very different. Yes, people who die by suicide, a lot of times the stats are about 40 to 50% of people who die by suicide have a diagnosed depression or bipolar disorder, but only 4 to 7% of people who with depression die by suicide. So there's this reality of we can't just keep treating depression and thinking that that is going to be treating suicide. Yeah, antidepressants are helpful. Obviously, talk therapy, super huge fan of it. And we probably need more specific interventions that are endorsed and trained, people who have some training and suicide-specific interventions to really help that number of people who are dying by suicide. Because if we're just treating depression, we know now that it's not reaching everyone. So what do we do? How do we know if someone is suicidal? So I'm going to introduce this concept of the interpersonal theory of suicide. Now, this was created by Thomas Joyner and Kim Van Orden, Dr. Rudd. some really great work. And if you're interested in this at all, I really encourage folks to seek out more education and resources on this. There's a great book, but there's also lots of articles if you don't want to engage in all of the reading. But it really sort of identified sort of three aspects that make someone suicidal, and that could make a suicide attempt more lethal, right? So we have this Venn diagram here and some evidence that when these three concepts overlap is when we're at their highest risk for completion or a serious attempt, so a really lethal attempt. And what these are described as a perception of burdensomeness, a thwarted belongingness, and an acquired capability of suicide. So we're going to break these down a little bit more. So the perception of burdensomeness, again, this is, people have probably heard this before, but it's when the individual believes that they are so defective or flawed that not only that they're down, but their sort of being brings down others, or maybe that they're in such constant crisis that they are a burden to their friends or family. And so this might resonate with a lot of you, this concept of feeling like a burden. We see this a lot with people who are maybe of older age, feeling like a burden on the family, right? Someone who has a chronic illness. I think one of the ways to sort of, it's just a really good, if you're a clinician or caring for someone, it's a really great thing to look out for, of this talk of being a burden. And as a therapist, sometimes I really try to neutralize this and talk about, yeah, you might be an inconvenience to friends or family sometimes, right? Like I know myself, I'm a pretty level-headed, stable gal, and I still have little crises where I know I can inconvenience some friends and family. And I know that they would gladly take being inconvenienced by me than to lose me, right, in the face of a crisis. And so I think, again, sometimes to normalize that, yeah, sometimes we can be an inconvenience for friends and family, but that doesn't mean that our life is, that we're worth more to them dead than we would be alive. But again, if we're thinking about, again, the etiology of suicide, what makes someone suicidal, certainly this concept is almost always present, this perception of burden. The second tier of this interpersonal theory of suicide, or what makes someone suicidal, is this concept of thwarted belongingness. Right. And so, this can be loneliness or social alienation, but really it's this thought of, I used to be part of a group and now I'm not. I used to have a clan. I used to have somewhere I belonged, and that has been taken away from me. So again, one of the highest risk groups for completion of suicide are men over the age of 55. And we know what happens after 55 for both men and women, so that we were nearing the age of retirement, maybe not till 62, maybe not till 75, depending on where you're at. But retirement can be a huge alienating experience for people. Another group where this has really been studied is veterans coming home from war. They're not deployed with their unit anymore. They don't have that unit. I actually had the chance to work with veterans of the NFL through the National Football Association, right? And also there, right, these individuals who, have been in a locker room since 4 years old, and now they're 32 with the body of an 80-year-old, and they don't have that kind of integral part or group, right? And so again, if we're sensing this, if someone has this sense of lack of belonging, right, then that, again, a huge risk factor or something to kind of tune into. It's not to say that everyone who goes through those life-changing times is going to experience suicidality, but something to be curious about. And again, when we're thinking, if more of these concepts are present, the higher risk folks are, and the more likely that there could be a lethal attempt. And there are some interesting stats on the thwarted belongingness. And so I just share these two kind of interesting things that I just kind of find phenomenally interesting in looking at thwarted belongingness. And there's been two studies where suicide rates have gone down in times of national crises, or when a city sports team unexpectedly wins a competition. So again, sometimes during a national crisis, there can be this banding together, right? And obviously, if you're big into sports, a big win can sort of lift everyone up. But there's these two concepts. So again, 9/11, most people are familiar with this in 2001. Again, you probably heard me mention that these days the average rate of suicide by day in the United States is 120, roughly, deaths per day. So this is looking at the dates before 9/11 in 2001. So 9/8, 9/9, and 9/10. The deaths were around the mean or within the range there. So 93 deaths, 91 deaths, and 96 deaths. The day of 9/11, there was 36 deaths by suicide. The day after 9/11, there was 24 deaths by suicide. So pretty phenomenal in terms of what this banding, I mean, if you remember that those days, the day of 9/11, the days after, certainly a come together to mourn this horrible tragedy, to support each other. And people clearly, by these numbers, there was an increase in belongingness, right? And again, there's more going on than that. Maybe it's correlation versus causation, but certainly a pretty phenomenal piece of this, right? So the importance of belongingness in helping to prevent suicide. The next sort of piece, maybe a little lighter topic here, is looking at the specific date of February 22nd. So in a 10-year average, the national average of deaths on that day was 89. The range was 72 to 120, but on February 22nd, national average of deaths was 89. But on this day, in 1980, there was only 47 deaths. So, over less than half of normally people who died by suicide. Because for those of you who remember or know this history, it was the day of the Miracle on Ice. So the U.S. ice hockey team beats the heavily favored Soviet Union 4-3 at Lake Placid in one of the biggest upsets in Olympic history. And Americans go on to win the gold medal. So super fascinating. Again, this piece of belongingness, right? So if you're into sports, you might remember this day or just might know it. I'm a big sports fan, so I know that sense of belonging and people coming together. Again, maybe a little bit more of a lighthearted anecdote there, but certainly sort of stressing this piece of, again, if you are someone who's caring for folks who have mental health concerns, who are identifying suicidality, watching out for this sense of lack of belonging, and even also going so far as to try to increase belongingness, right? That's why we have groups and, encourage people to use their social networks, because, having a sense of belonging in and of itself can be life-saving when it comes to suicidality. This third concept that's identified in the interpersonal theory of suicide is the acquired capability for suicide. So, again, our amygdala is sort of here to keep us safe. It's part of our brain that sort of is all about self-preservation. And so to die by suicide, you need to override this. And it's often there is people have to have some fearlessness to sort of override that part of our brain that is protective. So something to be aware of in terms of, obviously fearlessness can be really helpful, but we see there are certain groups of people who have a higher risk for suicide. And that is often people who put their life on the line on a daily or weekly basis or always, right? So our first responders, firefighters, police officers, again, our military and retired military, there's something in them that they've been able to override, right, that sense of self-preservation to be able to do their jobs. So just having that in and of it alone does not make them automatically a higher risk for suicide. But in the face of additional mental health concerns or a thwarted belongingness or a sense of burdensomeness, that having that trait can definitely make someone higher risk, right? Or even people who've had previous suicide attempts or who have kind of fearlessness of death or pain. Sometimes we even like people who have gotten a lot of tattoos or, have a really high pain tolerance. Again, it's just there's something in their brain chemistry that overrides that sense of self-preservation a little bit more. So I don't want people walking away from today and saying like, well, Meghan said people that get tattoos are higher risk for suicide. That's not what I'm saying. But certainly there's a piece of this in light of suicidality or suicidal thoughts. It does make someone higher risk. Again, particularly when it's coupled with these other concepts of the interpersonal theory of suicide, including thwarted belongingness and that sense of burdensomeness. So something, again, to watch out for. And again, when we looked at those myths at the beginning of our talk today, we identified, people who have maybe like sublethal attempts or, people who talk about suicide. Again, that can all be priming people to be less afraid of suicidality. So again, a huge risk factor does not make someone less likely to die by suicide if they've had previous non-lethal attempts. It makes someone actually more likely to die by suicide. So, I think today is not meant to be a training on suicide risk assessment. And I'm just going to share a little bit of information about suicide risk assessment. There's some reality that it's difficult to predict any human behavior, right? I think even though we've looked at this data, suicide is a statistically rare event still, luckily, right? I mean, again, increasing numbers concerning, but it's hard to sort of study because it is a rare event. There's no lab test to predict the behavior. Professional preparation is usually lacking in this arena, right? It's often like a day or a week in graduate school. Suicide is the result of multiple causes, right? So it's not just one thing. And I often say that errors can often be made from a good clinical decision that's made from a poor, incomplete database. And what I mean by that is people who are suicidal might not want to tell folks the whole story, right? And so I think there's times that as clinicians, it's hard to predict because we often don't have a complete database. I say database in meaning like all the information. We don't always have all the information because there's what they're telling us, there's what there's not telling us, there's what we're concerned about, right? So there's lots of information, which is why it's really helpful to use something like a standardized risk assessment because it helps to sort of gather as much information as you can to make the best clinical decision that you can in order to help people. So here are some risk assessment tools that I really like. Cheryl mentioned I'm part of the Zero Suicide Initiative here in Madison. They have really great resources on the Zero Suicide website, trainings for the Columbia Suicide Severity Rating Scale. There's a really great 1-hour webinar on counseling on access to lethal means, which is really great. I've been trained in CAMS, which is the Collaborative Assessment and Management of Suicidality. That one's not free, the other ones are, but also really great, created by Dr. Job. So lovely. And then Sean Christopher Shea has a really great book on the chronological assessment of suicidal events. So I just want to put that out there. Again, today was not meant to have you all walk away being masters in risk assessment, but I think super critical when we're thinking about how do we understand suicide? Well, part of it is being able to do a risk assessment and getting all this information. Another piece of information I want to include, especially, again, I don't know who you all are out there, but there's a lot of you who might not be clinicians. There's a reality, though, you can still be really helpful. Being able to listen to people, being able to ask questions to help keep them safe is super huge, right, in terms of keeping people on the planet. So safety planning, a standard safety plan, again, that you can find on the Zero Suicide website was created by Stanley and Brown. Lots of versions of it out there, but safety planning is an attempt to build on any ambivalence about suicide that may already exist. Safety planning is not a no suicide contract. There is data that is not helpful, but rather it's an intervention and a prevention tool to keep someone safe. So here's a little screenshot of a safety plan that I use here at the hospital, but lots of resources out there. You'll have access to these slides after the event today. And so lots of resources out there, but Stanley and Brown have a really great one. You can find that on the Zero Suicide website. So we've talked a little bit about what makes someone suicidal. And you heard Cheryl's call to action at the beginning of today on how do we prevent suicide and wanting to prevent deaths from despair. So I say the best way to prevent suicide is you ask. You ask if someone's suicidal. You ask if someone's thinking about suicidality. And you ask and you ask and you ask. And that is the best way we can we can keep people alive is if we're willing to ask the questions, regardless of what kind of position we're in. If we see someone who's struggling, who's not themselves, who's talking about depression, being willing to say, have you thought about suicide, is, and really trying to normalize it. I did a suicide risk assessment this morning and sort of said, most humans have thought about suicide at some point in their lives. So you are not alone. I want to know more about, how you're thinking about this and what you're thinking about. But I think there's this reality, especially if you've been working in this field or supporting someone who's been struggling with suicide for a long time, we get overwhelmed, right? We're asking these questions, and then something happens, right? There's this reality of there are people who need care, right? There are family and caregivers who are in pain in trying to care for their loved ones. There are providers who take care of people at work and at home. So what happens when caregivers don't have the space to talk about their own pain and their own fears? What happens to professionals who provide assessment and care to patients with chronic suicidality? Because we know that can be an exhausting world. Can we do this work when we ourselves are struggling? That's a huge question, right? If I'm having a bad day, if I'm anxious, I always say I myself run a little more anxious than the average bear. So how can I help someone if I am anxious, right? And how can I do this work when we're struggling? Or how can I be an expert when I have failed my friends or family? So I'm going to share a little bit of personal information here. I've been studying suicidality really since about 2009, but around 2011 got pretty heavily focused on it and started doing a lot of trainings and presentations and being asked to do things like this today, and was really loving it, right? I'm all about suicide prevention. It is so near and dear to my heart. But this really interesting thing happened to me, and I say interesting, a really horrible thing happened to me. I was asked to do this training. It was May 11th, 2016, and it was a conference on prevention, postvention, and response. I did this training in 2016, and the next day, I lost a very good friend to suicide. And it was the first time not the first time I lost someone to suicide, but when I look back on these dates, it is really remarkable. Here I was in a big auditorium presenting on this, and I missed something. That's how I kind of take it away. So I share again my understanding of suicide. So I'm just going to share a little bit more about myself here. I remember learning about suicide, but the first interaction I had with suicide was I'm from a really small town, and someone in a different class in my high school died by suicide. And it was kind of the first person I'd ever known to have died by suicide. And I remember being at my friend's parents' house and talking about it, and they said, suicide is selfish, right? So a lot of you maybe heard this phrase before, that, it hurts more people, it leaves people in pain. And I just, kind of as you do when you're younger, I just took that as the gospel and was kind of put that in my brain, and suicide is selfish. And, I kind of knew I always wanted to be a therapist, but that obviously became more distinct when I got into college. And I, had my first sort of interaction with it within the psychology classes, and maybe my first first grad school class even, and sort of thinking, how do I keep people alive? How can I do this? How can I work with people who are suicidal? And how can I fix this? How can I save this? And just sort of real bewilderment. It was probably around that time that I was like, maybe I don't want to work with people who have suicidality, right? And I experienced an additional loss at this time. A friend of mine died by suicide, and I just developed a lot of fear about it. Probably even more standoffishness in terms of, how can I be helpful to people? And that's really when I dove in. Typically, I have this unfortunate or maybe fortunate habit. When I'm afraid of something, I sort of lean into it and go all in. And so started getting a lot more training on it. And I think I reached to a point where I would say there was a little bit of complacency I had been referred to as an expert, quote unquote, a few times, and that felt really uncomfortable. But I thought I had a lot of understanding about it. I had a lot of capability. I had some competency with suicide assessment and prevention. And that's when I lost this really close friend of mine. And I think it could have thrown me back, right? It could have taken me back to not feeling capable. But I think luckily I had a really great support network that helped me move forward with humility, right? And move forward to be really even more focused on prevention, to validate the pain that people experience in suicidal crises. I don't want to accept that it's okay that they're in pain, right? But I do validate it. And I felt very much more focused. That's when my work with the Zero Suicide Initiative really increased in terms of prevention, right? And supporting the whole community and helping people who suffer from suicidality versus just thinking it's in the hands of mental health providers, right? We all have this obligation to help keep people alive. So again, we're going back to my otters holding hands. This can be hard work, and we are in this together. And so I appreciate you listening to a little bit of my story. I think other people have found it helpful for me to share that, but I think it's really helpful for me to sort of, again, be refocused on why are we doing this work, and that we can actually be quite impactful when we lean on each other to continue doing this work. Because if we don't ask for help, we're going to burn out, right? If we don't sort of say like, I don't see the point anymore, or I'm not sure if I can even be helpful, suicide's inevitable. When we start hearing these things, that's when we do have to lean on each other. So we're going to talk a little bit about provider self-care here. I like this comic. It says, it's a smoke detector. The boss thinks I might be headed for burnout. So I think there's a reality of, I think certainly with the pandemic, we have been better at talking about burnout and compassion fatigue, I think, as a healthcare system. But it's because it's even more prevalent than it ever used to be, right? But I think a lot of times my experience with burnout was, it's just something like people talked about, and it was basically your problem to fix. Like if your smoke detector is going off, you better go get some help. Actually, I wrote a paper on this in grad school, kind of like trying to debunk burnout, that it was just kind of victim blaming, right? Which maybe is a little extreme, but it does seem that way. It's like, oh, if you're burned out, what are you doing? Are you taking enough baths? Are you going on enough walks? Like, what are you doing differently to take care of yourself? And I'm sure that's a part of it, but that kind of misses the whole systems look at it, right? Like, why are we burning out? And so again, I don't know who you all are on the phone and on the TV, whoever's watching this, but I would imagine that some of you are providers who do feel burned out. I would imagine some of you are caregivers and loved ones who do feel burned out sometimes, right? And so what are some more systems answers to that versus you taking a few more hot baths or going on a few more walks, which do those things. They're great self-care. But not the whole answer, right? So just going to briefly talk a little bit about compassion fatigue. Before I talk about compassion fatigue, I like to identify compassion satisfaction, right? That our motivation to help is going to be partly, derived from the fact that we get something out of helping others. We enjoy working and helping others. So again, kind of a helpful grounding tool that we don't get fatigued by things that we don't really care about, right? If we don't care about something, it's going to be harder for us to be fatigued by it. And compassion fatigue has been described a lot of different ways. There's burnout, there's vicarious trauma or secondary trauma or compassion fatigue, right? But basically, they're all saying the same thing, that because of the work you're doing, because of the help you're giving, you yourself are experiencing some emotional strain, right? And how is that possible? Well, there's a concept called mirror neurons. We're going to get a little help from my nephew Cecil here. So I have a picture of him to prime us for a little bit of help. Maybe some of you have heard of mirror neurons. I love talking about mirror neurons because a lot of times in my science world, there's not always hard and fast answers of things, right? So I do like it when there's some hard and fast answers. So mirror neurons are the answer to the question, why do we react at such a gut level to to other people's actions? How do we understand so immediately or instinctively their probable thoughts or feelings or interventions? And I think about this a lot, when you see someone who's in pain, like maybe your face grimaces, sometimes even when I see someone about to drop something, even if they're across the room, like I reach out my arm to try to catch it, even there's no way I'm gonna be able to catch that thing. But there's a reality of like, we respond to those primers. Or if you see a little boy eating a lemon slice, there's no way you are looking at this picture and your lips aren't puckering a little bit, imagining my nephew Cecil's experience here eating a lemon out of a glass of water at a restaurant, right? So there's a reality that none of you are probably biting into lemons. And I bet if you're really thinking about it, your glands are salivating, you're experiencing some of those same sensations as if you were biting into a lemon. So the answer of that is mirror neurons. So watching an action and performing an action can activate the same part of our brain in humans, which is lovely to know, right? It gives this concept of compassion fatigue, I think, more validity and more understanding that being around pain, we're going to experience that pain too. And empathy and emotional work are our energy at the heart of effective work with people. So you're bringing it, right? It's not so much you just being around it, you're exposing yourself. If we think back to Freud's quote of you're never so defenseless against suffering as when you love, right? So when we are trying to support someone, we're bringing even more of that compassion, which in turn sometimes increases our risk for that fatigue. So there are risk factors, right? A lack of improvement or results, exposure to trauma, feeling alone with it, like a sense of I'm responsible for this, right? All risk factors of feeling that burnout. There are protective factors too, right? Sometimes this innate empathic ability that I'm sure a lot of you have can be a protective factor. You don't have to like turn it on, right? You just at your core, you have some empathy. If you have a good work-life balance, if you're feeling effective or satisfied, right? Like I'm able to be helpful. That can be a huge protective factor. You see progress. You have some rational detachment, or you have an ability to be self-compassionate. All can be protective factors. It's not simple math, right? So it's not like, okay, great, I have eight risk factors and 2 protective factors, I'm doomed, right? We know that's not quite how this works. The reality is how this works is if we're able to have some acceptance of where we're at and some willingness to change. So some of you might be familiar with the concept of dialectical behavior therapy, or DBT. We are not getting into a lesson on DBT right now, just a little snippet that the term dialectical means the synthesis or integration of opposites. So how do we tolerate something uncomfortable and be kind to ourselves enough to be able to be motivated to keep going, right? And that's that piece of self-compassion that I think is so helpful. It's being able to extend compassion to oneself in instances of perceived inadequacy, failure, or suffering, right? So it's about being able to accept that I don't like where I'm at right now. This is really painful. I feel ineffective. I feel unhelpful. I feel scared. And, I deserve some kindness here. I'm not alone. It's okay for me to be in pain, and I'm going to ask for help. These are self-compassionate words. I'm bringing in another mentor of mine here, Dr. Allen, who used to always say, it's important to take your relationship with yourself seriously, which often in my earlier days promoted an eye roll for me. And now I'm on board. You're right. And I think, again, the concept of self-compassion is harder for me because I'm a goer, I'm a fighter, I'm going to keep going. And there's a reality that to be self-compassionate, we have to be able to be vulnerable and slow down and identify feelings, right? So again, we know that self-compassion is a huge protective factor against compassion fatigue, against burnout. So that means we have to be able to practice self-compassion. We have to be able to integrate it into our worlds, especially if you are caring for folks who are struggling, right? Whether that be professionally or personally. Being exposed to that, you need to have some space for self-kindness and acceptance. So one of the tools I really recommend folks access is what's called the self-compassion mantra. This was developed by Kristen Neff. She has a great website, selfcompassion.org, with a lot of free resources. She has a few books out there as well. But the self-compassion mantra is something that I really encourage folks to seek out, especially if self-compassion is new for you, right? Because again, to be able to have that self-compassionate voice in your brain, you need practice and space and repetition, right? So some examples of self-compassion mantras include concepts of mindfulness. So being able to name in a moment of common humanity. So knowing that suffering is a part of life. Caring concern, so that willingness to be kind to yourself. And some intention, giving yourself the compassion you need. Your mantra should have those concepts of mindfulness, common humanity, caring, concern, and intention. This is my mantra. So in this vein of being vulnerable and transparent with you folks, I already told you I'm a little anxious. So my mantra is, this is anxiety. Everyone has this emotion. It's going to be okay. And sometimes it's okay to be awesome, which is a patient quote that has a whole backstory. But again, for me, that tells me that it's okay to be anxious. When I'm able to say I'm anxious, it almost automatically makes me less anxious, right? And I do know things are going to be okay. So that willingness to have a little bit of this response of a self-compassionate part of you, I think is going to make us all better able to be able to be present when the people we love or the people we're taking care of are hurting, especially with things like suicidality. It's going to make you better able to be in that pain with them and be in that moment with them, to be able to do that assessment we need to do and do that prevention work that we need to do, especially now that after spending the last 45 minutes with me, you have a little bit more understanding maybe of what might make someone suicidal. So hopefully I didn't talk too fast. I've really enjoyed talking with you folks and sharing some of this information. I want to open it up to questions now that I believe Kara is going to help facilitate.
Yes.
So what do you need? What would be helpful? Any other questions that you guys might have?
Yeah. And thank you, Meghan. I just want to take a chance to thank you for such a thoughtful and informative presentation. You make a difference, and I feel lucky to know you. So thank you for giving this presentation. And like Meghan said, we'll open it up to questions. So for those of you who are watching live, if you haven't already, you can feel free to text or call or email in your questions. I'll be watching out for those, and I will share those with Meghan. I think one to start, Meghan, that we can start with is, if you had one thing that you could say to someone who is suicidal, like what would that one thing be for everyone out there, whether they're a provider or not? Like what could they do for that one thing to say for someone who's suicidal that might make a difference?
It's a great question. There's a reality that there's not one thing, right? But I think the one thing you can do is you can listen and you can ask the question. I think, one thing you could say is, I hear you, I'm with you. You could ask how you could be helpful. You could tell them that they matter, right? So they're kind of depending on who this person is to you. There are some different ways to go there. For those of you who are not providers, there's some really great resources called Question, Persuade, Refer, or QPR training that's actually offered through Safe Communities that can help you maybe feel a little more comfortable with asking some of those questions if you're not a healthcare provider. I think regardless of if you are or not, you can sit with them and listen to them. Because people being able to tell their stories takes some of that intensity and pressure away from it. It actually can even help people create more of that ambivalence that I mentioned earlier. Ambivalence is good when it comes to suicidality. We want to build on that wish to live. Even if we can't reduce the wish to die right away, we want to increase the wish to live. And so being able to have connections and talk about it, again, when we think about interpersonal theory of suicide, it's going to make you feel less alone. It's going to decrease that thwarted belongingness if that's present. So that willingness to listen is pretty huge.
Thanks, Meghan. And that's a good call out to the QPR training too that Safe Community offers through like their gatekeeper training, which you can find on their website. And that was one of, actually, Tom and Jean did a webinar for us already for how to save a life, which is, I think, very similar along the lines of that. So that's another one for those of you watching that you could watch the recording. The Ending Deaths from Despair website is on Safe Communities, and you can find all of those. So those are really good suggestions. Thank you, Meghan. For another one, thinking about like self-care and your own burnout and all of that, what has helped you? And you were so raw and open with all of this, and I appreciate you sharing all of that from your personal life. Like for you personally, for burnout in the field, what has helped you stay focused and not burn out in the field that you work in?
Yeah, I think community has been the biggest thing for me. So I think sometimes the idea of learning more about a topic that you're already feeling burned out in is maybe the opposite of what you would think. But for me, I have found like so much humility in the suicide research world. Like, I feel like in terms of mental health research, there's a lot of like proprietary stuff of having to pay for different trainings. I feel like in suicide research world, a lot of stuff is free. People are just like, take what I did and make it better if you can, or use it. So I have just found the community through Zero Suicide so helpful in terms of my own self-care. Obviously also stepping away, right? Having backup for coverage for work and things like that. Having a really lovely family and that kind of balance is key. But I think in terms of when I think about what's helped me from burning out, is it's having a group and having a community that I can draw on for support and to support me when I've experienced losses.
And I think all of that you just said, and even in the presentation, whether you're a provider or a clinician, or you're on the supporter side of just a loved one, I think all of these tips we can draw back to do that self-care and that self-compassion and not burnout in whatever field you're in, but in caring for other people. Thank you.
Yeah, absolutely.
Looking through, I think we have time for another question. Here's another one. What advice do you have for clinicians who don't have a lot of specific training, like specialty training in suicide? What tips do you have for them if they're watching?
Yeah, I mean, it's probably kind of obvious, but I would say get training, right? So I know that can be overwhelming. Luckily, there are a lot of free things out there, right? So there's this webinar, there's the Zero Suicide website that's sponsored through the Suicide Prevention Resource Center, so SPRC. It's a really great resource. It's a clearinghouse of trainings and articles. And so I would say don't be afraid. Like if there is something you don't know about, it's okay to not know. And identify it. And, if you work in a clinic or work in someplace, encourage your managers or whoever does education to sponsor more of these trainings. Because I think this is pretty huge. I teach at UW-Madison, so I have a whole week on suicidality where I share everything I know. But there's not as much education about this that's baked in because it's one of a million things that folks need to learn about. So not bashing the education system. But I would say that there are resources out there for you. You do have to be a self-starter and be willing to access some of those. And you can feel free to contact me if you have questions about it or want more recommendations.
Thanks, Meghan. A couple more questions have come in. This one, someone's a provider. So I'm a provider with a patient who is chronically suicidal. Is it possible to ask her too much or too often if she's suicidal? She already told me how I can support her, but I don't know if I should just keep checking in about it or not. Any guidance on that?
Yeah, I think one of the things you could do is work with the patient to develop language that feels supportive without feeling interrogative. You could also ask about has anything changed since the last visit, right? So not thoughts in the last 30 days or thoughts in the month, but since our last visit, have you had these thoughts? Have you had these behaviors? And sort of take it on that. Because a lot of times folks with chronic suicidality, again, they might be really used to it. I think if they have a safety plan where they're willing to share it, other times, we would say to reassess at change of status. So if anything sort of changed in their life, they should kind of be formally reassessed, not even if their suicidality increased. But I would encourage you to work with the patient specifically on language of since the last time we talked, what has changed.
Those are good suggestions. Thanks, Meghan.
Yeah.
Okay. Looking at the time, I think we have no more time for questions. If there were any more, Meghan already made herself available for that. So I think we've come to our end of the time today. And again, I just want to thank you again so much, Meghan. And thank you to all of you who are watching out there, all of us joining today, or maybe you'll be watching the recording. Thank you for watching the recording. Thank you for being a part of the Ending Deaths from Despair Task Force webinar series. And we hope that you'll attend a future webinar and that you'll spread the word to others in Dane County. Thank you all so much.
Thank you, folks.